Sure. I'm here with Deepinder Dhaliwal. Deepinder, you bring such fun topics. So this one's, I don't know if it's fair to call this fun. So you gave a wonderful talk on cataract surgery through compromised, difficult corneas. And by what I mean by difficult is I mean difficult for the surgeon. Now, you very rightly make the point that it's unfair to lump these all into one basket. There are different sorts of cases. You broke it up very nicely. Why don't you break it up for us now?
Sure. So when we're dealing with corneas that are suboptimal and we have to do cataract surgery, we want to optimize our outcomes, obviously. So I just basically broke it down into categories. We talked about anterior pathologies such as epithelial basement membrane dystrophy, keratoconus, talked about endothelial dystrophies as well, and then talked about some post-surgical cases.
Yeah. So let's start right with number one there.
Okay. So when we're dealing with surface issues, we have to have that conversation with the patient. If they have significant epithelial basement membrane dystrophy that's causing irregular astigmatism, you got to have the conversation. Do we want to take care of that ahead of time and then possibly optimize their surface and put a toric lens in if they have significant residual astigmatism? Or if perhaps they're just not interested and they're a little elderly, maybe they just want to have cataract surgery, and just because they've been living through these, kind of aberrations for a long time, that's okay too, because I tell them we can do this on the back end, but when I do cataract surgery for those patients, we simply aim for a little bit more minus, because if we're going to do a PTK to take care of their issues post-operatively, we want to have that little cushion. Most patients, though, want to take care of it ahead of time, and so we do a superficial keratectomy, allow the cornea to heal, usually about 6 to 8 weeks, and then repeat the keratometry and proceed.
So those are for anterior corneal difficulties.
Yes.
What if we move a little bit more posterior?
So in terms of the stromal issues like keratoconus, so we are operating on a lot of keratoconics, and the implant selection has always been very challenging because some of these corneas are very, very, very steep. And when you look at the formulas, they sometimes say you need to put a minus lens in. And, our results were kind of all over the place. And then we found this amazing article that was in the BJO in 2014. And in this article, it basically had stratified keratoconus into mild, medium, and severe. And the most interesting thing is in patients that have severe keratoconus with Ks greater than 55, we now just use an average K in all these patients of 43.25, and then we aim for minus 1.8. So, and that's the IOL that we use. I mean, it sounds too good to be true, but that has actually been very beneficial. And in those keratoconus patients, again, we have the conversation, do they want to wear rigid gas permeable contact lenses post-operatively or not? And if they don't wish to wear contact lenses, then we offer them possibly a toric lens to correct the regular component of their astigmatism. If they say, no, I love my contacts, I still want to wear my contacts, then we stick with a non-toric intraocular lens implant for them, just to keep it simple.
Now, keratoconus cases are difficult from a surgical planning standpoint. They're not typically difficult from a surgery standpoint, but that's not true of all stromal pathologies.
Right. If you have a very hazy cornea, so I presented a case of actually a patient with a mucopolysaccharidosis where his cataract surgeon tried to do the cataract surgery, and on the table, the surgery had to be aborted because the view was too hazy. So this patient was referred to us at the UPMC Eye Center, and we looked at the cornea. It was very hazy. There was a little bit of edema, a small anterior chamber depth, and we were able to use femtosecond laser-assisted cataract surgery, and it was game-changing. We used the Victus laser in that case, and it was brilliant. It worked like a charm, and even though I could hardly see, we were able to get this cataract out safely And we then did the patient's other eye, and he's like a new man. And we didn't have to do a corneal transplant in order to see the cataract, and his visual recovery has been wonderful. So that, I think, the femtosecond lasers, when we're dealing with really compromised views, can be extremely helpful.
You would think, I would think that the compromised view would pose a problem for the femto too. That would cause a lot of femtoscatter, but the proof of the pudding is in the extracting the quadrants, or however the saying goes.
Exactly, and we used different settings. We had the engineer there with us, so they helped us bump up the settings, and we kind of, we modified the technique a bit. But the key with anything, when you have a hazy view, use trypan blue for at least 30 seconds. That's been critically important. And when I put the trypan in, I actually burp the paracentesis, so I have less aqueous in the eye when I'm putting the trypan in, so it's not a dilute trypan mixture. And I set the timer for at least 30 seconds so that really you can stain well, and that helps tremendously with the visualization.
Now, for my patients with Fuchs having cataract surgery, I amongst the many things that take place during my counseling is I tell them, yes, I'm of course going to be gentle during cataract surgery, but the truth is that I attempt to be gentle with all of my cataract surgery. But that's not totally fair. There are modifications that you can make during cataract surgery to optimize outcomes with Fuchs. Can I get you to talk about that?
Absolutely. So when we're doing a Fuchs patient, first of all, ahead of time, they know. They have two problems, the Fuchs dystrophy and the cataract, and we're just taking care of one of them. If beforehand they wake up with morning blur, then I know their cornea is decompensating, and I prepare them that they're likely going to need endothelial keratoplasty in addition to their cataract surgery. However, if they're waking up and their vision's equal morning to night, then we proceed with cataract surgery alone, and here are the key things. Make a little bit of a smaller rhexis, about 4.5 to 5.
Why is that?
Because in case that patient years later or immediately after needs endothelial keratoplasty, we're going to shallow that chamber to do a DMEC. Mm-hmm. We want that lens to stay back. So you want to keep that rhexis size smaller. We also make sure we put in a hydrophobic acrylic implant, because with hydrophilic acrylics and air, you can get some calcifications. And we aim for a little bit of minus. Even with DMEC, you should aim for some minus to account for the hyperopic shifts that we get post-operatively. So those are the key things. We make sure we do phaco in the bag. Keep that phaco energy away from the endothelium. So we do a stop and chop technique, so we have space in the capsule to really take out those quadrants, and we don't bring them up anteriorly so much. And we use tons of viscoelastic. The dispersive viscoelastic is just wonderful. And we coat, and if it's a very dense lens, we recoat after we get half of that nucleus removed.
Well, this is great stuff, very practical stuff, really good tips, the chief one of which is that if there's a complicated cornea that they're going to see Dr. Dhaliwal. I want to thank you for making this also very neat for us, and as always, Deepinder, for being so very generous with your time with us.
It's an absolute pleasure. Thank you so much for inviting me.